All right, everybody. Hello and welcome to this webinar, the third in our series on managing severe behaviors. I'm Jill Escher. I'm the president of the National Council on Severe Autism. Very happy to introduce to you Kelly Bermingham, who is your chair today for this webinar. I will be kind of signing off in the background. Kelly, please take it away and let everybody know how you are going to run the show today.
Sure. Thank you, Jill. So welcome, everyone. I see that people are still joining. That's great. We're told we have lots of participants today. So we're so excited that you are joining us. This panel is near and dear to my heart. I'm super humble and thankful to be invited to chair this panel. We've picked some experts in the field that are doing some kind of different work in the realm of severe and profound autism. So I think you're in for a treat. How we're going to do this is I am going to start off sharing my screen. I'm going to ask that there is a Q&A. If you have questions for myself or any of the panelists, put your questions in the Q&A. Certainly use the chat to engage and chat with each other. I see people from Arkansas. I'm seeing folks from New York. I'm seeing folks from California. So I love that you're all listing in Iowa, you're listing where you're from. Oh my gosh, look at all of you. It's so fun to see. So let me talk about our day. And Jill, can you just confirm folks can see my screen?
Yes, ma'am.
Okay. All right. So we are on the third we're the third part of this topic of talking about treating challenging or dangerous behaviors. You have myself as the host and chair. You are going to hear from Dr. Robin Epstein, Steinberg-Epstein, who I'll introduce. You're going to hear from Dr. John Guercio. You're going to hear from Dr. Jacobson, and then Steve Perez, my coworker, is going to be our discussant for the day. So what we're going to do is we're going to try to tell a story, if you will. This is going to be a story. And I'm going to start it off by talking a little bit about the history of ABA. I am a BCBA, and in putting together this panel, we all had a really nice discussion about the history of our work. And myself and our panelists have been in this field for a long time. And in the 1994, actually, is when I first started working in this field. And I worked in Massachusetts with adults, with the adult population, adults that had grown up in state institutions, particularly Massachusetts. The Fernald State School was one of the main state institutions that was being closed down. And our job, it was the wave in the 80s and 90s to move adults who grew up in state institutions, because that's what families were told to do, put your child in a state hospital. By the 80s and 90s, we realized that was not the right thing to do. And we started moving these adults out into the community. And so, in the 1990s, there was not a BACB. There was people, just good people trying to do good behavioral work. And it's interesting in our field sort of started to shift from adults and adolescents who maybe were on the more severe end on to younger and younger children and early intervention. And we know as a field, as ABA providers, which we're going to be talking a lot about behavioral strategies, as ABA providers, we are a very young field. Over 50% of ABA providers, BCBAs, have only been in the field for the last 5-6 years. So it's a young field. So we think it's important to really focus on these kids, go back to these kids that are more severely impacted, more profoundly impacted. And so I have, just to kick us off for our story that we're going to tell, the Drexel Autism Institute came out just recently with their national indicators, and we know that autistic adults who received DD services are more likely to have a comorbid intellectual disability, right? About 60% of adults on the spectrum who live with their family had an intellectual disability, and 75% of those who do not live with their family. We know that there are high levels of co-occurring health and mental health conditions in this field, which makes the behavioral and the sensory world very confusing and challenging. We also know that families report inadequate planning for emergencies. About 4 in 10 families, 40%, don't even discuss a plan for handling crisis and emergencies at their person-centered planning meetings. So this is a really important topic for a lot of families. Dr. Rachel Taylor and some colleagues published this article in May 2020, and they basically talk about that of BCBAs, and those are the folks leading the behavioral therapy in a lot of organizations. These BCBAs, they did a survey. 43% of respondents had been assigned their first severe case without initial or ongoing support. Secondly, only 35% of respondents received training on functional analysis just one time. And finally, 5 respondents, 4%, answered that the majority of their work was with clients 19 years or older. So we're a really young field still, and we're not necessarily training and supporting our therapists who are doing the work in this topic. So I want to do a little bit of a plug here. I am on the Council of Autism Service Providers. I am the co-chair of the Profound Autism Special Interest Group. And we are a group that are committed to work on this topic. And we have sort of 3 main areas we're focusing on with this special interest group. One is talking about the actual diagnosis of autism. Kathy Lord came out at this Autism Science Day of Learning in September and introduced a new concept about profound autism. If you go on their website, you can watch her 15-minute video. It's incredible. And she talks about how lobbying sometimes impacts the DSM-5 diagnosis information, but that they found that profound autism might be a better way to diagnose and actually label those kids. Let me move my picture down here, or adults. And what she said at this talk, was that there is discussion that a diagnosis of a profound autism is not appropriate to be applied to very young children, that beginning at age 8, it's possible to use the diagnostic term profound autism, but it's defined by an IQ of 50 or under, and minimally verbal or speaking in single words. I'm not Kathy Lord, I'm not the expert in this, but I did watch this video and I found it very important. And our CASP group also looked at this video. And so we are working to talk about diagnosis of the term from severe to profound. Our CASP group is also talking about what are the standards and training that we think folks should have if they're working with the severe and profoundly impacted adults with autism and or IDD, and their quality of life. So our group is also in the middle of going through a review and discussion of restraint and seclusion in the next few months. CASP as a whole is addressing this, and we'll be putting together a white paper and or conference on what we think are the best standards of training requirements for those working with severe and profound autism. So today, our story is going to look like this. we're going to have Dr. Robin Steinberg-Epstein. She's going to present 30 minutes on the neurological and sensory processing experience and underpinning of challenging and dangerous behaviors. This all starts with your doctor, right? The doctors are the people. So she's going to talk about that, her perspective as an expert in the field. After she talks, we are going to have the Dr. John Guercio. He's going to talk about his assessment tool and a book that he has written about assessing and tools and strategies for working with those with severe behavioral challenges. Next, we're going to have Dr. Erik Jacobson, and he's going to talk through an approach that I am so excited about that his team and some organizations are putting together that's called Happy, Relaxed, and Engaged. And it is going to be amazing to watch this approach that his group is doing. And then at the end, myself and Steve Perez will do a discussant of what we've learned. And we will also be monitoring the Q&A and the chat while we're doing this. So if you have specific questions, put them in the Q&A. This is going to be recorded, and the slides and a whole recording will be made available to anyone. I saw that question. So we're going to start now. Dr. Epstein, would you please jump on this? Jump and show your lovely face.
I'm
awesome.
trying.
You got it. So I'm going to turn this over to Dr. Steinberg-Epstein. I've known Dr. Robin Steinberg-Epstein almost 20 years, I think, at this point. When I moved from Massachusetts to California in 2002, I right away started working with her and Dr. Donnelly. We work together at UCI, where she is a developmental pediatrician. She is well known in the California community for not only her diagnostic information, but the care that she continues with her families, that she treats hundreds of thousands of kids she's seen over the years. And Dr. Epstein, I'm going to let you take it away.
Okay, we had a little bit of difficulty at the beginning, making sure that you all could see. So I'm going to check to make sure. Can you guys see my slides?
We see your slide. It's not in full presenter mode.
As long as you can see the whole slide, I'm good. Is that
okay? I'm going to drop off so they can see better.
Okay. So thank you very much for having me here to speak. It's a really important topic. I think that a lot of the research and attention is paid to certain parts of the spectrum, and not enough is paid or not enough research is done in the area of severe behaviors or severe autism. I did see a comment while Kelly was talking that I thought was, that I also agree with, which is that I also agree with the person who said that Kathy Lord's description of profound autism being for kids with an IQ of under 50 is being a little bit too restrictive, because I do think that there are kids that float up into higher IQs for sure that have profound impact from autism. And I think it's important to keep this discussion going, and for hopefully there to be a discussion on what that would look like. So as a physician, I'm not involved so much in the behavioral or sensory aspects other than to be aware of them and try to give some guidance. But a patient comes to my attention with severe behaviors when they're in my office, and I'm trying to help guide parents in terms of what next steps would be, or how to intervene, or how to support their child or adult. And I'm going to probably say child a lot because I work mostly with children. So when I think of severe behavior, I think of a behavior that harms or hurts the individual or others, keeps them from accessing activities of life, such as eating, sleeping, participating in functional activities, of being able to participate in activities to improve their own quality of life, such as school, play, or family, or behaviors that decrease the ability of others to care for them. Examples of some mild to moderately severe behaviors, again, in my mind, would be eating such a restrictive diet that it ends up resulting in nutritional deficiencies or failure to thrive, perhaps long-standing anemia, which some people don't think of as a big deal, except for over the course of many years can lead to cor pulmonale, or a chronic irreversible sort of cardiac issue where part of your heart thickens and can't pump effectively. A person who's screaming, throwing, hitting when not getting their way, or when things are changed. For an older child or young adult who is perhaps more verbal, but they are threatening to harm others in public. A lot of our folks have something called cognitive distortions because they have difficulty with their language skills and social skills and misinterpret things or create their own theories for explanations as to why something occurred and falsely accuse or attribute behaviors to other people. And then irritability and anger and threatening to harm can ensue. An example might be an older child or an adult who's taking off their clothes in public, a child who escapes in the middle of the night on a regular basis, trying to climb a fence and jump into a neighbor's pool, yelling at teachers who changed the way that something should be done. Yesterday, a child who choked other children and their teacher and a speech therapist and their one-on-one aide all in one day. And it's been escalating aggressive behaviors. Something that would be a more mild but can become more severe are simple things like rubbing your hands together to the point where they're raw, cracked, infected, biting on your knuckles to calm yourself down. It doesn't break the skin, but it's creating a lot of calluses, and over the course of time can cause some skincare problems. Some very severe behaviors might be screaming for hours without any determined antecedent on most days. It's really hard for people who are trying to care for those children and adults to withstand that kind of stress, as I'm sure many of you know, much more than I know or experience. Smearing, eating feces, sleeping less than 4 hours a night, pulling out their own teeth or biting off parts of their fingers or lips. This is another example of a patient of mine who was obsessed with one of their siblings, wouldn't let her leave the house. And when the mother tried to intervene, threw the mother through a plate glass window, resulting in 100 or so stitches. Trying to smother an infant sibling because the baby was crying, and so creating a sensory discomfort. A child who insists, or a young adult who insists on banging their head on a window that can break. Putting objects into body orifices requiring hospital removal or emergency room visits, choking a driver or jumping out of moving cars. And part of the reason why I'm listing those is that when I made this talk, it was during Autism Awareness Month, and I live in a home where I have a child with autism who does not fall into this behavior category, and was arguing with me about some of the interventions that you're going to be talking about, or that people use to work with kids and adults who have autism, and trying to relay the information about what is a serious behavior that requires intervention. You can't leave those situations without intervening. So self-injurious behaviors, 50% of people with autism at some point demonstrate self-injurious behaviors. Much of that is really early on, when they might be learning to communicate and they don't have a way of communicating, or they're trying to get attention. Those do not cause serious harm. You often outgrow that when your communication skills or your behaviors improve, or you're more able to deal with more sensory input. But there is a substantial number of people who have more severe behaviors. Those behaviors, as Kelly had mentioned earlier, are more likely to occur if a person has comorbid intellectual disability, if they're younger, if they're minimally verbal, patients who are more, or people who are more impulsive, people who are more rigid, if you've had loss of skills, so regression, is common in that group, partially because it may indicate a comorbid intellectual disability. And if they have unpleasant health issues, for example, eczema in a young child who can't express that they're really itchy, and so they can't sleep at night, and they wake up and they scratch themselves to the point of bleeding, and it hurts, and so they start head banging. Someone who has constipation and they have stomach pain, which is causing them, they can't express it, and so they act out due to an unpleasant experience with pain.
Excuse me, Dr. Epstein. There is a request for you to make your screen, your Zoom. So if you go up to the display, like we did earlier, so people can see the full slide.
Is that better?
Yes.
Okay.
Thank you.
So as a physician, when I have families come in, it's the first thing we want to consider is kind of what I just said, and I'll come back to that, which is there something acutely wrong that I need to address? Are there self-injurious behaviors or screaming and crying because they're in pain or discomfort? And I'll come back to that. But in a general situation where this is a long self-injurious behaviors or severe outbursts or severe behaviors are more of a constant, we want to consider some medical conditions that may predispose to that. So there are some genetic conditions, something called Smith-Magenis syndrome, where kids will pull out fingernails or insert objects. And that can be a clue that they actually have that genetic condition. So a young lady who was repeatedly putting small objects into her ears and her nose that required them going to the emergency room to have those items removed was a clue that we needed to take a look for Smith-Magenis. Cornelia de Lange, where children hit themselves a lot. Prader-Willi, where they're picking their skin. This is the genetic condition where children and adults will eat uncontrollably without satisfaction. They'll break into drawers and cabinets in the middle of the night to eat. They will overeat all day long, and they tend to be extremely large. Metabolic syndromes like Lesch-Nyhan disease, where they'll bite off their lips or poke out their own eyes. And neurologic syndromes like Tourette's syndrome, which we actually see a fair amount of. So tics that are causing severe behaviors that become very painful, or they are doing things that other people find unacceptable in a repetitive fashion. Tourette's is oftentimes associated with OCD as well. And so considering if that's a possible etiology or origin of severe behaviors. And that's super important, because if it's a tic behavior, parents will at first assume that a child's doing it on purpose. And education to help parents understand more about the neurologic condition, or any of these conditions for that matter, helps to decrease some of the anxiety and anger that families might feel. Any kind of structural brain injury is important, so via an MRI or also severe neglect. So children that came from an orphanage perhaps in Eastern European countries or in other countries where the protections are not so clear. And this can happen for neurotypical children or children who have any number of conditions. Then obviously we, as a physician, we're going to be looking for comorbid medical or psychiatric contributions. As I said before, like obsessive compulsive disorder might cause some pretty significant behaviors that lead to, they're expressed as severe behaviors. They can also cause physical damage to a person. Severe anxiety, and this one is super important because autism, anxiety is part and parcel to autism, and it is oftentimes a trigger for many of the severe behaviors that we see, and especially to consider in people who are verbal who have autism, they can tell us. In people who are minimally verbal or nonverbal, they can't tell us, but we assume that based on their behavior that they have just as much, if not more, anxiety, and that needs to be that needs to be addressed either behaviorally or from a medical point of view. Psychosis is rare, but is something we also want to consider as a comorbid condition in autism. Neurologic medical causes such as PANDAS, which is an autoimmune response to strep infections and can cause a rapid onset of obsessive compulsive behaviors or ADHD behaviors or tic behaviors. So considering doing an evaluation for that. And then, as I said at the beginning, it's important for us to identify, is a child having headaches, or is an adult having headaches that are causing a sudden change in their behavior? Do they have reflux that they're not able to tell us about? Could they have a brain tumor? Do they have appendicitis? Any kind of pain can obviously cause an acute change or change in behavior that is a priority for a physician to consider before you go on to receive behavioral interventions. The research is really not conclusive. I have some information about some of the research, but there really isn't a clear pattern as to why some people demonstrate severe behaviors. So the neurochemical contributions that have been looked at are several of the neurotransmitters like dopamine, serotonin, glutamate, GABA, and the opioid systems have all been looked at, and there's a little bit of research to support and a little bit of research to refute in each one of the situations. Naltrexone is a medication that blocks opioids in your body, and this has been tried and found to be helpful in a small number of patients. There's the question of whether or not self-injurious behaviors induce pain to distract from something else that may be happening, or is it that their brains misperceive the neuronal input from a pain receptor, and actually it may feel good to cause themselves pain. Are they trying to hurt themselves with the idea that after you hurt yourself, you have a release of opioids, and that opioid makes you feel better than the initial pain? Or are they trying to just communicate? And those are some different theories that people think about. In animal models, they can induce self-injurious behaviors in rodents by giving them pemeline, which blocks dopamine and norepinephrine. And again, this is sort of looking at, do people who have self-injurious behaviors have too much dopamine or norepinephrine? If that were the case, then we could just give medications that block dopamine or norepinephrine, and that would cause a decrease in the self-injurious behaviors. But in fact, treating the self-injurious behaviors or severe behaviors with certain medications have not been consistent across the board. And again, as I said before, the altered pain perception in a variety of brain studies, and whether or not this is causing them to have pain or whether it's a response to pain is not clear. So from my point of view as a physician, I have someone come in and they have a severe behavior. And the first thing I'm looking at is this an acute change? If it's an acute change, then I need to try to figure out why. Has something changed in their environment that's causing this particular acute change? Are they in pain? Is it a medical condition? If it's a long-standing severe behavior, then I want to make sure that we've exhausted behavioral interventions. And some families that come in haven't used or don't have access for some reason to behavioral interventions. And we want to make sure that we try and help to provide education and help navigate, at least in the United States, a difficult healthcare system to be able to access some of these services. But the bottom line is we want to make sure that we've exhausted all behavioral interventions. We know that there's no medication at this point in time to treat the core symptoms of autism. Medication only treats the associated behaviors or the comorbid emotional and psychological components of autism. So I said the anxiety, for example, which is not a core symptom of autism, but occurs in the vast majority of people who have autism. And we know that ADHD does not often respond to behavioral modifications and often needs medication. And ADHD is comorbid in autism about 60% of the time by most studies that have been looked at. So when I'm considering medication, I look at 3 core target areas for medication. Is the behavior a response to anxiety or rigidity, arguing, black and white, something changed? Or is it a very impulsive, hyperactive, inattentive trigger for the behaviors that I'm seeing? Or is there an underlying irritability that leads the person to be very difficult to manage despite having intensive interventions? The medications that we oftentimes consider are medications for the anxiety and rigidity and OCD, which the first line is usually an SSRI, which is a selective serotonin reuptake inhibitor, like Prozac, Paxil, Zoloft, Lexapro. Another group might be the alpha medications like clonidine and guanfacine. These were originally blood pressure medications, but we note that they decrease activation, they help with tics. They are now looking into that they also help with anxiety. And that was sort of an anecdotal and surprising finding because guanfacine was approved as a treatment for ADHD. And it was noted that in the population of those who have autism, that they tend to show a reduction in anxiety, outbursts, and irritability. And it's a very safe medication that's easy to use. Propranolol, some people use for anxiety, stimulants for hyperactivity and impulsivity and inattention, mood stabilizers and anti-epileptic medications that are used to treat mood lability, atypical antipsychotics like Abilify or Risperdal or Seroquel, and then more experimental type of medications such as naltrexone or Namenda, excuse me, are often tried. As I said, we want to really take a close look at the severe behaviors and try to figure out what is the antecedent or the cause of the behaviors. We want to make sure that there's a routine. The routine should be established in a visual format, even for kids who are very verbal. So we've found that some parents who feel that their children are really verbal and are very, very capable don't want to use a visual schedule, but in the moment when a child's overwhelmed, their language falls apart and visual schedules can be extremely helpful. Front loading and preparing for changes. And I'm speaking to the choir because I'm sure many of you already understand these things. Consistency and consistency in parenting, consistency with other people in the homes and other therapists that are in the child's environment. Speech therapy to help improve communication, physical activity, sleep hygiene, eating at appropriate times with regular intervals with a good diet, if possible. In certain subsets of children who are more verbal, cognitive behavioral therapy, and then obviously ABA or behavioral therapies. So from our perspective, we're going through this type of thought process to make sure that that the family is on the same page with us and that behavioral interventions have been optimized. I do want to say that when COVID came into the picture, it was interesting because a lot of families didn't utilize or access, as Kelly was saying, an emergency plan. And even people with autism who are functioning relatively well, you needed to go back to basics, such as making sure that there was a well-established routine, a visual schedule, that you were front-loading, explaining to them what was happening. There needed to be consistency. We wanted to try to access and therapies in any way we could. What we're finding from the research, and we don't have a lot of it because obviously COVID is still happening, is that for some of the groups with autism, that they were able to utilize therapy and medical appointments via telehealth, but that kids who had behavioral problems before and adults who had behavioral problems prior to COVID, and those that were more severely impacted with intellectual disability or less language, were unfortunately unable to access or benefit from some of the telehealth and teletherapeutic interventions, and they were again, as usual, left out, and their families were left to fend. What are some psychosocial contributions to behavioral therapies that we think about? Divorce. So are we able to use the same types of schedules and front loading and behavioral strategies in both homes? If there are grandparents in the home, there are some great grandparents out there, but there are often times where you have grandparents who have a different philosophy and they don't help to the stress in the home if they're still, if they still believe in some prior theories of that the parents are at fault or that they're just not disciplining their children enough, or if they themselves are not willing to institute or implement behavioral strategies that can create some significant behavioral problems. Parental mental health, if the parents aren't in a good place, then it's really hard for them to implement some of the behavioral strategies that are needed. Then there are some real live difficulties. If you're living in an apartment or with multiple families, it's really hard to allow your child to tantrum or to ignore certain behaviors because you're worried about getting kicked out of your apartment or a multiple family situation. There are laws to protect from that, but if you are in a truly underserved situation, those laws may not protect you as well. For example, if you are illegal in the country, that may not be as protected, or you may be fearful that you're gonna be deported if people find out that you're causing difficulties in your living situation. Financial resources. So during COVID, we saw that families had to go to work and they had to leave their children with less supervision, and in some cases, minimal supervision, despite a child really needing to have that type of supervision. Also health insurance, whether they have it or not and have access to behavioral supports. And then abuse and neglect. And again, during COVID, we saw abuse and neglect increase. So in general, we think that oftentimes we need to use medication and behavior in severe situations. Not always, but and medications are sort of a last resort, but we oftentimes need to do that when a person is demonstrating behaviors that are a danger to themselves or others. I'm not really going to go into complementary and alternative medical interventions here because obviously that could be a panel in itself. But we also need to consider what a family is trying as alternative treatments to try and help with behaviors. Just to mention, there's a CBD study going on in San Diego, which is great because it is a double-blind placebo-controlled and it's a well-run study, but we have some patients who are on the study and I have seen actually negative outcomes so far of all of the patients that are in that study at our site that I've seen. THC has consequences for people specifically under the age of 25. I'm not saying that I totally disagree with its use in some children, adults, or families, but we need to understand safety aspects of complementary and alternative medicines before we always jump into using them. Some medications that are being given now commonly, for example, for ADHD, actually, one of the side effects is hyperactivity. Several years ago, people were using St. John's wort because it was a natural solution for anxiety and depression, and it resulted in liver failure in 26 people in the United States requiring a liver transplant. So it is important to discuss complementary and alternative medical interventions with your doctor. They also need to know that because if they're going to be considering medication, sometimes what you're doing from a complementary and alternative intervention does not mix with the medications that are being considered. So my approach is, number one, make sure there's not a medical issue. Next, is it causing significant disruption for the child? And I have that highlighted because sometimes families will come in and be very upset about a tic or about a repetitive behavior such as flapping or stimming that doesn't cause the child harm. The child or adult is using it actually to self-calm, but the family doesn't like the way it looks, or it bothers them, or it embarrasses them, and they're asking for medication to stop that behavior, which is not an appropriate use of medication. We want to make sure that you're optimizing behavioral therapies and language and education programs. We want to see, has anything changed in the person's life that could be causing these behaviors. We want to look for psychosocial contributors and try to control for things. And then lastly, if all of those other things are looked at, then we would consider medication if the behaviors are danger or impairment not improving. I will jump immediately to medication if the behaviors are so severe that I can't wait to do a lot of the other things on this list. What do I think people mean when they say no ABA? And this slide is referring to some recent criticisms of ABA. And I've gotten into several discussions with my son and others. And it seems that many of them are referring to the original rigid Lovaas style discrete trial ABA, where at times they even used, where you're using restraints, and you sometimes still need to do that in kids who are very, very, very severe, but not necessarily. And ABA has evolved, as Kelly was saying, over the course of time and taken on many different types of modifications. So I think that there is still definitely a significant role for ABA, but it should take into account the person that the service is being delivered to. It should not be aversive, but it should be intense. And I just mentioned the repetitive behaviors. I don't think we should replace repetitive behaviors that are a self-calming tool, and that ABA can be used to teach daily living skills and social skills and other things. And I do think that helping people to optimize their abilities and their skills to the best of their ability. So this last point comes from the concept of ABA as a conversion therapy, and that we should love and accept all people with autism the way that they are, which I do love my child with autism, and I think we all love that person in our life with autism, but we also want the best to do the best that we can for them. And every child, neurotypical or not, they go to school to try to learn to read, to learn to interact, to learn to socialize, to learn to be able to manage life independently. And I wouldn't want to exclude all people with autism from those same opportunities. So I do think it's important that we continue to work with people to improve daily living skills and social skills to whatever that person's individual ability is. ABA is a model under construction. We started with strict low-VOS discrete trial aversive therapies, then non-aversive ABA. We now have sort of combined approaches where we use behavioral analysis and include elements of any number of approaches, which you all would be talking about. It's not a one-size-fits-all approach, and it's important to respect people's neurodiversity while also optimizing their ability and freedom to live in a pain-free, not struggling environment. The quality of ABA is super important. Without some sort of standard, we see a variety of implementation of ABA, and I certainly have to talk to a lot of parents about what should we expect from ABA, when do you want to have your ABA modified or consider changing the ABA delivery model or the company, because there, at least in Southern California, there are a lot of companies. Some are very good and some are less good, and your team that you're working with may not be implementing ABA the way that that's best for your child or young adult. And we need to be looking at the needs and the ability of the family to utilize the strategies that are being taught, and the degree of impairment matters in terms of how much ABA is appropriate, whether a child or an adult is improving from the intervention. There has been some recent research showing that whereas before we thought that every person should get a certain number of hours or an increasing number of hours, that for some people, ABA in a more intensive, better delivered model, but for fewer hours, might be better for one family, but another family may benefit from more hours. So really looking at an individualized approach. My concern with the potential damage of an anti-ABA movement is that ABA in the United States is still not approved in multiple states. So insurance will not pay for ABA in several states. So arguing against utilizing ABA for all people with autism really is a disservice and deprives those families that need it the most. And so I'm concerned about people expressing it. They can say, I don't want it, or it didn't work for my family, or maybe we need to look at the delivery of it. But to have a movement against ABA, I think is detrimental, because there are lots of people that want it. So instead, or need it. So instead, we need to advocate for ABA in a broader sense and minimize aversives, except in the most severe situations. We're now seeing some schools suggesting that we stop social skills interventions and support for children who have maladaptive behaviors, because people with autism are saying that they don't want to be changed. So why are we intervening? So again, that would be potential damage from this movement. A lot of the people with autism who are trying to get rid of behavioral therapy are in a position of privilege. They themselves are often verbal, are often the recipient of significant interventions early on. And they might not have been able to advocate in this way if they themselves did not receive the interventions. But in the end, who speaks for those who cannot, and who has to care for those with these behaviors? There is a concept of disability, and are we going to call autism a disability or not? And this needs to be discussed more. And I think that I'm kind of out of time. So I'm going to move on and allow you all to discuss what you're really here for, which is behavioral interventions and not medication, and what I as a physician see as important. But hopefully it offered some information.
Thank you so much, Dr. Epstein. I'm excited that people got to see your brilliance. Come back for a second. Come back on screen for a second, Dr. Epstein. Yeah. So I'm so excited everyone got to see your brilliance. And I'm going to just do a quick summary and a couple questions so we can move on. But a couple things that have come up through the chat and through the Q&A that I want to sort of bridge the gap to our next panelist is, one, how important and unknown all of these things are, right? So there were some questions like, how would you diagnose some of these conditions you're talking about? Are you doing genetic testing? Can you just talk about that a little bit, about all of those things that the medical issues you're addressing?
So from a genetic point of view, in terms of what is the main cause of autism, and we believe that there is 80 to 85% of the time there is an autism component that, there is a genetic component that plays a role in autism, and we're finding out more and more as we do whole genome sequencing, looking at families where you have 3 or 4 people with autism. Some of the conditions that I did discuss are specific genetic abnormalities. And I noticed Jill is commenting about 10 to 15% are direct. And we know that there are specific genetic contributions that we can identify in 10 to 15% of the cases, but we actually are identifying many more now when we have families that have 3 or 4 members of the family with autism. And we're seeing hundreds of candidate genes where a family has an abnormality and it runs throughout the entire family. And that is the cause of autism. So it's many more than just 10 to 15%. And there's absolutely a genetic contribution. And it's been looked at in several large countrywide studies, in fact, that look at this same statistic. Some will say 70% contribution, but really it falls in that 80% range. And I can get you those, that information. So, okay.
Okay, so hold on. Jill, do you want to hop on?
Sure. I do feel that this, I love the presentation, by the way, loved it very much. I do think that this really requires some clarification though, because this is one point where you are wrong.
Okay.
The genetic studies show consistently that about 10, maybe up to 15% of cases can be explained clinically by genetic mutations, and those are not autism specific, by the way.
No.
They're usually relating to syndromes that may or may not, have any, autism symptoms, or may have other symptoms, right? Other mental disabilities, for example. But no,
let me just stop for 1 second there, and we'll address the other part in a minute. But actually, the 17% number is actually that they have a genetic abnormality that is directly related to autism. So the syndrome has autism as part of the syndrome. So it's definitely not that they have a syndrome and it's not linked to autism. They have a syndrome that is associated with autism at much higher numbers, like Prader-Willi, like Down syndrome, like I'm just blanking right now, but there are a lot of them.
Listen, this is a tangent to the topic, but it's really, really, really misleading to say that 80% of cases are genetic. 80% of cases, up to 80%, are heritable. That's not necessarily genetic. We can talk about it offline, but I feel that point really is important, and it was an error. But anyway, great presentation otherwise.
Okay, and I would say that my what I said was a genetic contribution, not a genetic abnormality. Genetic contribution in 80%, and that is what the Nature article says, and several others. So I think whether heritability to me is genetic because it's coming through the genes, but and therefore, like if a family of 4 people, that it's in the genes and it is caused through genetic lines. But in any case, okay. What was it? Another question?
So I'm gonna, I see that Jill, that heritability is not the same as genetic. I'm not a doctor, so I'm gonna not engage in that. What I think, although I appreciate it, what I think this really just highlights is how complex all of this still is, right? How much we don't know. And as practitioners, behavioral therapists, one, we need to work so closely with the doctors because our functional analysis, right, we often have to work alongside with the doctor because functional analysis might show, like your point about someone injuring themselves to release the opiates to diminish pain was so crucial to say because it's such a complex intertwined issue. So the points that I want to take away, and we'll move into our next topic, are also looking at the acute changes versus the longstanding. There were several comments about dental pain and how complex of an issue that is. And I know you and I worked on that dental study, Dr. Epstein, and so I'll put that in the chat so people can see that we know that's complex. But it also shows, one, that there needs to be decision trees. There needs to be a decision tree model and around how we identify and analyze the health issues, the emotional issues, the family dynamics. And as behavior analysts, we need that decision tree working side by side with the medical community, as well as a decision tree around the amount of hours and services that we're providing as ABA practitioners. We're past the age where everyone gets 30 hours, right? We're in a time where we need to make those decisions based on diagnostic information, adaptive information, family information. So with that, thank you so much, Dr. Epstein. Everyone in the chat is applauding all of your work, so thank you. We're going to now move on to Dr. Dr. Epstein, you can, thank you. We're going to move on to Dr. John Guercio. Will you pop on, John? Great. So now now that we have this intersection between the medical information, right, the family information, as practitioners, we are working out through a decision tree model with the family and the medical person. I'm going to turn it over to Dr. Guercio because he has written a book on this topic and assessment of how to treat severely challenged behavior. So I'll be quiet. Take it away.
All right, thanks so much, Kelly. I really appreciate that. And going to put my slides up here, and we're going to start talking a little bit about assessment. And I do want to preface my comments by saying there's a fantastic article on what Dr. Epstein was referring to recently that just came out days ago in Journal of Autism and Developmental Disorders. It was by Justin Leaf. Laurie Unum was also an author. So it is clinicians and family members, parents, that actually, there's an article that summarizes the concerns about ABA-based interventions. And they go through and they address each one of these, from the early Lobos studies that were at UCLA, what's going on today. And I think it's a beautiful synthesis to be able to talk about what these issues are and how individuals can navigate this, because it is a big issue. I think that the number of forums I've been in lately, that's the number one topic. So I didn't want to see here on my cover page my email address. I will go back to that at the end, because I think that's the best way if we're looking for slides or information that we can actually share that information with you. So the facts. I think the number one thing that we're looking at is that there are a greater number of individuals being diagnosed with autism than ever before. I think that is without dispute. A number of reasons why, and I think, like Dr. Epstein had mentioned, it would involve another panel to discuss that totally. So a number of individuals, adolescents and young adults coming into the system. And I think that as we see a lot of that, I see so many individuals, we serve individuals from the ages of 14 or 15 all the way up to 60 plus. And what we see is that, I always tell my family members, and I always tell new BCBAs getting into this, that new BCBAs typically want to work with young children with autism. And I think that's what's out there today. And Kelly mentioned the history of the field. I've written a series of 3 papers on the history of our field that goes all the way back from 1860 all the way to the present, and the Third Wave Act and other interventions. That thing's very interesting. So we've been around a lot longer than than a lot of people would admit. So I think that as we're looking into this, we have to look at the increase in prevalence. There's a huge demand for appropriate services for adults, adolescents and young adults with autism spectrum disorder. And I think as we look at this graphic, I think one of the biggest things that you see here is that there are a number of individuals, if you're looking at by age, if you look at the adults 18 plus, which is the second bar graph from the right there, and you look at the amount of resources spent on those particular individuals, and these are our estimates, but the numbers are way up there. And I think that justifies what we're talking about in terms of these levels of supports. So resources, very scant. I think we know that. Employment, community residential services for individuals on the spectrum continued to demand far exceeds what the resources are. And so I think as we're looking at that, there are a generation of individuals and their families that right now there's a lot of programmatic, financial, and personal limbo. And a lot of this information, I took from Dr. Pete Gerhardt. We've had a number of conversations about this. And I think that if you look at the literature in 2004, Howland surveyed about almost 70 adults. And what they found is that the average age of these individuals was almost 30, with autism and a performance IQ of above 50. And a majority of these individuals were rated as having poor or very poor outcomes. So I think that this begs attention. So as we're talking further, individuals with performance IQs, you're looking at 70 plus, that they had significantly better outcomes than those with a performance IQ below 70. Okay, we'll talk a little bit about why that might be possible here in a little bit and why that happens. So within the normal IQ range, outcome was variable, and on a case-by-case basis, neither verbal nor performance IQ really were any significant contributing factors in terms of this. So we know with employment, I'm going to talk about employment a little bit. I think, with time frames allotted, I'm only going to be able to touch on the tip of the iceberg. So that's why I'm going to leave my email at the end. I want to be able to continue the dialogue. So the authors found that only 8 of the 68 individuals they looked at were competitively employed. Okay, that's a significant number. So when we look at quality of life, the authors in 2006, Jen Cousins in this article sought to assess the quality of life of young men. Okay, and these were mean age of about 20, so pretty young individuals, college age with what was then called Asperger's syndrome in Canada. So all these adults were matched with ASD were reporting, as I mentioned earlier, lower quality of life than those in the control group that were language matched, but typically developing peers. So 50% of this group are unemployed. Those who worked earned about half of the amount that those in the control group did. So I think as we're looking at this, one of the things I've come across is I've really tried to look across the nation for what states do it right. Pennsylvania have a lot of things on their website where they actually talk about supports for individuals with autism that are adults, young adults. And so if you look at the projected number of adults with ASD receiving services in Pennsylvania, look at that projection out to 2030, and those numbers are phenomenal in terms of how that curve is growing. So as we look at this, we look at, okay, what are our transition programs? What do these services look like? So in the US, there was a study in 2008 done, about 200 families, and they looked at these individuals that were at this transition age where they're just going from school-based supports all the way up to adult services in Southern Florida. And they found that almost 70% of the families had no knowledge of transition programs. Over 80% relied on family members as their primary source of transition planning. And almost 80% were unfamiliar with agencies they could go to get help. So I think that's a pretty significant calling card for us to be able to look at this and to say, okay, here's what we need to look at and do. So only 19% of individuals in the study with autism were employed. 74% that were employed worked less than 20 hours a week. That's a separate topic as well. We struggle all the time. We have individuals that want to work more than 20 hours a week, but then it impacts their SSI, and that's another story altogether. 85% still live with their parents, siblings, or older relatives. And overall, outcomes were generally regarded as poor with all the things that we've talked about, and I think for good reason. So I know we've all had lunch. I'm not trying to kind of gross you out, but I think a picture is worth 1,000 words. So I think that as we're talking about these issues, I want you guys to grasp, along with what Dr. Epstein described, with individuals with certain syndromes biting their lips off, or individuals engaged in severe scratching, eye gouging, that significant behavioral issues. When I do a search for significant or severe behavior in literature, I see studies of young kids, which is fine. That's great. That's what our field is doing. These are adults, though. There's not much that's out there. And that's what, my contribution is in this situation. So I'm not going to spend a lot of time on these, but, these are just slices of what I see in my daily life in terms of individuals I'm intervening with, young men being restrained by police after attacking police officers. Same thing, they would go on self-injurious behavior, cutting, destroying property. That's the Barnes Jewish emergency room there. A young man that was being admitted to the emergency room broke the window on his way in addition to assaulting officers. This young man engaged in SIB by biting his arm. So I'm not going to belabor the point, but I do think that needs to convey, this is what we're working with. This is what we're addressing. And I'm going to give you some solutions on how to do that. So fantastic book that I train our staff on, and it bases everything that we do. And I'm not going to show you the video, but this is Dr. Tony Biglin. And it is his Nurture Effect book that he published a few years ago. This is fantastic in talking about how most of our society is based on coercion, okay? Murray Sidman wrote a book, Coercion and Its Fallout, years ago, and this really backs it up and talks about how our science can impact our lives and kind of change the world for the better with this construct of nurture, and he really operationalizes it. And that kind of undergirds everything that I'm going to talk about today. So initially, I'm going to kind of start out and kind of show you some of the literature, some of the things that we've done, and then I'm going to get a little bit into the curriculum and kind of what's involved there. So this is a paper that we put together a couple of years ago. We published it in Behavior Analysis and Practice, and we looked at stimulus fading procedures in order to look at treatment resistance in an adult with autism spectrum disorder. And we see this all the time, but it's not really addressed in the literature. Okay, we had a young man that would not ride in a van. And whenever he did, it was very dangerous. I saw somebody in the chat earlier talking about choking the driver. That's what we saw. Throwing things at the driver, trying to go over the front seat to get to the driver. No explanation needed there as far as how dangerous that is. So these are some of the things that we're looking at and trying to intervene on. We also have had a recent article that Mark Dixon and I published in 2011 looking at staff interaction styles. Okay, and I'm going to talk a little bit about that because that also is a huge component and, in my opinion, the number one component of what we do, teaching staff the appropriate interaction style. Staff, doctors, moms, dads, brothers, sisters, whoever it might be, it's not what you say, it's how you say it. It's not what you ask, it's how you ask it. So I think that's what we're looking at. So our system here is built on a system of what we call PEARLs. And it's an operationalized, we've done 2 or 3 studies now in the literature where we've actually looked at how a positive interaction style can impact in a positive way the clients that it's used with. So we have different components, positive, upbeat, request, promoting positive behavior, intervening before problem behaviors occur, interacting with all residents. We have some staff that just have their favorites and they don't talk to everybody. And that produces jealousy and as a result, attention-seeking behavior. Praise for good behavior and looking for ways to teach. For those of you that have been in this for a while, that looking for ways to teach has been called active treatment in the past. And it's still very important today. And this graph will show you the impact of, excuse me, I'm slipping slides there, of what these types of interventions have in terms of positive behavior. So we looked at baseline measures. We looked at staff that in terms of the components of PEARL and what we saw as positive interaction, most staff, as the graph shows, were not intervening in a positive way at all. We then did what most organizations do. We had a training. And most administrators, hey, let's have a training. We have an issue. We need to do a staff training. Our literature is not the first, but there's a lot of our literature and behavior analysis that shows that training is not the way to go. Staff training is not the way to go. We see that you may see a brief change, but we don't see a lot after that. And in this particular study, what we did is after we did the staff training, we actually went and looked at observation where we had staff watch videos of an appropriate clinical team member and what a positive interaction looked like. And so as you can see, for all the individuals that did this afterwards, you saw huge increases in interaction style behavior across intervals, across time. So I think as we go through this and we talk a lot more, about that, it's not only the positive interventions, because in the previous study, you can see their interaction style increased and it was positive, and a lot of people would look at that and say, well, so what? And so our answer to the so what is that if we look at productive involvement of individuals when staff are positively engaging them, and again, I've searched the literature for years because this has been my research interest for about 30 years or more. And if you look in the literature about positive interactions, very little. And what you do find is not what I'm talking about here. So as we go through, we have staff observe and we see, and they implement this in residential settings, the productive involvement of clients increases. Okay, so as opposed to functional behavior, that's what we're looking at, as opposed to individuals maybe just watching TV or just going outside to smoke or whatever. Now, functional tasks that they're engaging in. We also measure what we call happiness indices. Dennis Reed first coined this in the behavioral literature years ago, and it is a number of indices for individuals with severe and profound intellectual disabilities, where you can actually go through and look at measuring overt behavior that you can get a happiness index or a happiness indices. And as you see from here across the board, the happiness indices. So operationalizing what is happiness, what is functional involvement, positive interactions enhance and increase both of these. So I think that's the core of what I'm going to talk about and kind of what the book is based on. So given the time constraint, and I'm hopping right into this because I usually have a prelude that I get into and I talk about how I train our staff and how that works and what that looks like. And I'm not going to have the time today. So I'm just going to give you some snapshots of what the assessment, and the assessment is the ASHA assessment. It's the assessment of adult core competencies, teaching skills to adults with autism and severe behavioral challenges. So this is something that there are other tools out there, and some of them, say that you can use them with adolescents and adults with autism, and that's fine. Most of those tools, though, what they're addressing are ADLs, and they're addressing maybe cognitive activities or learning or on-task behavior. It's not looking at the functional activities that, I told somebody the other day, this is great. We have these other assessments, but it's very difficult to be able to teach somebody, form or color recognition if they're trying to punch you in the face. So I think that a lot of the things we're doing, we're looking at what are some functional adult living skills that many times are overlooked and are not really put in curriculum type format. And so we've done that. And that's a little snapshot of this is a snapshot of what we use for social media. We have a social media assessment. And I'm not going to have the time to kind of get into why we've had to put this in place, but many of our individuals are using these. They're using phones and they're getting in trouble, and they're doing significant things that can cause legal or other issues. So we're looking at trying to teach functional replacement behaviors related to this. So I didn't show you the full scale, but essentially it's a number of items on a checklist related to a BARS or behavior anchored rating scale based on how the person or frequency in which the person engages in these behaviors. And, you see the last two bullets, they're not following guardian guidelines related to use of social media or inappropriate with email or other means of electronic communication. I've had many, many friend requests on Facebook or Instagram with inappropriate pictures of my clients. And so this has social validity in terms of being able to teach this. So this is a little bit of an issue when I describe this. This is something that, one of our young ladies was chatting with a friend, texting, and we teach all the time. That's fine. If you want to text, if you want to do this, this is probably not a good icebreaker picture to send. And I think a lot of our individuals don't understand that due to the history of either institutionalization or, I think, which is more primary, lack of functional teaching, where individuals have not taken the time to say, hey guys, this is something that we need to teach. One of the things I think that I'm the most proud about is our sexuality assessment. And we talk a lot about it in the book. And we have a lot of our clients that are not their own guardian, but they want alone time. They want to engage in sexual activity with their boyfriend, their girlfriend. And I think that in our field, in forums like this, we always say, yes, that's great. That's exactly what we want to do. But when it comes down to doing it, we're scared. We don't want to do it. We ask questions. We put up roadblocks. So this is an assessment that an individual can go through. They can have an exact score. They can find out based on the score if they are able to earn alone time for an hour, 2 hours, an overnight, based on observable, measurable behavior. And if they're not at a certain level, we can give them feedback and we can train on what is needed. So functional replacements. And we've got a young lady now that is, in her early 30s. She has had 2 or 3 children. And, I still had a guardian ask me to have her go through sex ed. And I said, really? Given what's going on here, we really want to have her go through sex ed. She's had 3 children. So we did it. And everything was fine, and we passed through, and she's earned her alone time. So I think that's one of the things, I really stand up for. We need to put our money where our mouth is. We're saying this is appropriate. How many of us would we want to say, okay, just due to X, Y, or Z, or due to where you work or your life circumstance, you're not allowed to engage in sexual activity. Okay, so just a thing, I'm not going to get an aside on that because it's a heated topic, but I really believe in it. So some of the adult core competencies, another example, we talked a little bit about it, transportation safety, and looking at, rating scales in each of the core competency areas. We have a scale where you rate the individual based on, their ability. Where are they? Currently, let's say with respect to transportation, in the COVID era, it's been easier. Individuals have been able to go through, and we actually have videotape. We have Station MD or WebMD where doctors can actually do face-to-face. But many times our funders are requesting that individuals go see the doctor face-to-face. And how do we do that without, waiting rooms being destroyed? I never will forget a couple of years ago taking a very physically aggressive and aggressive client who primarily engaged in property destruction, and walking into the psychiatrist's office and seeing a fish tank that was 2 feet high and thinking, oh man, this is about to wind up on the ground. So I think if we look at this, where's the client? Where's the person you're serving? They don't access transportation all the way up to they access transportation with no noted behavioral issues. And the intent with this curriculum is that you can walk people through as you would the AFLs, as you would the ABLs, the VB-MAP, any other current device that's out there, and measure over time and measure improvements and look at a scalar response to people over time. So tolerance for medical procedures, not accessing community-based medical procedures all the way up to attends medical appointments with minimal assistance. Okay, and I think these are important things to look at. Our focus is where it should be. I don't get me wrong, you know, in terms of manned and TAC repertoires and these types of things. But many of our adults, you know, have gotten to that stage where, you know, somebody mentioned Lobos earlier, and as we're looking at that 47% number, I think, of individuals that would no longer meet diagnostic criteria. Well, by my math, that still leaves 50% plus of the individuals that are going to need supports. And so I think as we're doing this, we need to look at what are some of the functional things that they're engaged in as adults that we can continue to work on that are functional in their lives. You know, it's great if we were to go through and do academic tasks or a number of other things, but our folks want to know about, okay, when can I have alone time? What can I do out in the community with my peers? Being able to go to medical appointments or do things, you know, on a autonomous or semi-autonomous level. So quick dip here. I'm not going to be able to spend a lot of time on, which is a shame. Again, this is a separate topic. We train on behavioral relaxation training. I recently published a book a few months ago with my mentor, my academic mentor from SIU in Carbondale, Dr. Roger Poppin, and a colleague of mine, Dr. Dwayne Lundervold. And we have a book, Behavioral Relaxation Training, and we look at applications with diverse populations. So the buzzword out there today is mindfulness, and this is kind of the behavioral version of that, and with operational definitions and kind of covering all the areas that we look at. And we have diagrams, as you see here, that we have our clients refer to. That, you know, what are relaxed behaviors? There are a series of 10 of those that we relax. We provide feedback. We also look at EMG, electromyography, feedback related to how relaxed the individual might be. We also have done certain things as an offshoot of that. We had a paper a few years ago where we looked at a stimulus avoidance assessment. Okay, a lot of things are out there. We know about a preference assessment, but what about an avoidance assessment? So we had a young man and we found the top things according to an assessment with procedures similar to a preference assessment. What are his top 5 things that he does not prefer? And looking at that to be able to have in vivo experiences and then teach him to be able to use a mindfulness meditation to be able to relax in those situations, to have a functional replacement behavior as opposed to spitting, kicking, throwing things, you know, those types of issues that he had typically responded prior to that. So this is just a little bit of an overview. This is a client that has gone through the system and our curriculum. As you look at, we have a system 1 through 5. And, you know, like we talked about earlier, lower numbers indicate increased levels of support. Higher numbers increase minimal levels of support, individuals that are moving in that direction. And so as we go through, we can kind of look at and measure where an individual is. And these are the majority of the areas we sample: transportation, community integration, okay, hygiene, chores, medical appointments, being able to attend medical appointments, vocational activities, vocational involvement. We do pre-vocational assessments, measures of well-being. We actually have operationalized self-esteem. So what's an individual, you know, what's it take for someone to have high self-esteem? We hear about that all the time, but this is something that we operationalize. And then looking at sexuality, what is something that we can actually promote active engagement in those repertoires that individuals express an interest in doing. So this is the book, Assessment of Adult Core Competencies, and it's available through Hedgehog Press. And I'll talk a little bit more about that. But, you know, as we go through it, I think it's important to look at there are a number of skills that we really need to focus on. This is the Behavioral Relaxation book, and it's available through Amazon or through Sloan Publishers. So just a couple of quick shots, I've got of individuals that have had, issues that we're now engaging in community activities where before they had been in intense psychiatric placements where they were not able to access independent community access or community access with staff, and they're doing that now. So I think the time is right, and I'm going to barely be able to touch in because I want to get to Dr. Jacobson and actually look at his presentation next. But this is in the news recently. We have a provider organization here in Missouri that we get a lot of information related to things that are going on, and both locally and nationwide. And the Better Care Jobs Act, I think, is crucial to what we do, the work that we do, the supports we provide for individuals with autism and developmental disabilities. And basically, President Biden actually has put a huge proposal out there to look at addressing what is a key need. The median wage of individuals who provide services, home care workers, direct support professionals, we call them DSPs, is $12 an hour. That's not a living wage. And about almost 20% of these individuals live in poverty, and many of them receive few or no benefits. So as a result, they're working 2 and 3 jobs. And so as a result, you're not delivering the type of service that you'd want if you're fatigued and you're burned out and you're having all these other issues. So this is something I think that we're looking at that is a very positive thing. High turnover with direct care and direct support staff, 40 to 60%. And I think one of the things that I've noticed that we've seen that the last 3 or 4 months has been the most intense, I think, that I've ever seen in terms of staffing shortage. And I think that there were a lot of unemployment programs that were out there helping individuals. But the unfortunate reality is that a lot of that money was keeping people from getting back into the workforce. So as those have ended, we've seen a lot more staff, but these individuals are the core for the supports that we provide. And I think that without them having a living wage, then, it's a very, it's a situation that has the potential to get worse. So I'm glad to see President working on that. And, in our state, we're working really hard on that as well. I've talked about some of the existing tools and, the things that we do. I'm going to go over a couple more slides and I'm going to transition off. But the foundation of what we do is staff training for all the folks that we have that come into our program. Every staff that comes in, we do an adverse childhood experiences survey on the staff. That is a ACEs survey. It's trauma. And we look at questions on, what are the individual scores with respect to a number of different areas. The ACEs, and this is the entire 10, it's abuse, neglect, household dysfunction. And we look at, and we do this with our clients as well, but how many of these did you experience prior to the age of 10? Physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, mental illness. If you had someone in your home with a mental illness, an incarcerated relative, substance abuse. And what we know is that having any of these 4 or more, we have a significant increase in the individuals that have the white matter tracts in their brain are not developing. And as a result, individuals tend to have more depression, anxiety. I think suicide is 12 times more likely in individuals with an ACE score over 4. So a lot of these studies that are out there are showing us the value of treating our staff as well as treating the folks that we serve. And I think that's the best way that we can do that. So I will leave you with this graph. This is just recent staff members that I've had go through, and I'll have them fill out the survey that we looked at here. Which of these things happened to you before the age of 10? And look at those scores. We've got some folks that are north of 9 or north of 8. A lot of individuals with scores of 5, 6, 7. Very few staff. We have some that are lower, but I think this merits looking at, and I think blending this into the approaches that we're using. So I'm going to end on that because I know that we've got a lot more information for you guys, and I'll stop there.
Dr. Guercio, that was amazing. So I am so excited other people are getting to see the brilliance of all of this work. So in our journey, in our story that we're telling is if you have a child or an adult on the severe, profound autism end, it does start with the doctor, the medical information, ruling out comorbidities, ruling out, or maybe not able to rule out, but trying to work together. And then what happens is practitioners providing the therapy, we need to do a proper assessment. And not enough people are assessing the types of severity levels and the important aspects that you just highlighted. So I put a link in the chat of your book. I highly encourage, I know everyone on this panel, we all have this book, you to, if your practitioner doesn't have it, have them get it. Are you doing any workshops coming up, Dr. Guercio, on the topic?
I am, with ABAC, the Applied Behavior Analysis Center. We actually are having one July 13th and 23rd, I want to think. It's assessment. So there's assessment, and then we're going into relaxation, staff training, and there are other modules that follow that in the fall. So I can get that information along to you for those that may be interested.
Would you put it in the chat? Absolutely,
you bet.
Okay. Thank you so much. So now we're moving from our medical team, our assessment tools, and now I have the privilege of bringing on Dr. Erik Jacobson, and an approach that, come on, yep, there he is, an approach that I found that he was doing that completely matched what I thought was appropriate in the field. And he has taken this topic and run with it. And I really wanted to highlight his work. So Dr. Jacobson, take it away. You're muted, Dr. Jacobson. There you go.
There you go. I'm on it.
Thanks.
What I did just say right there was thank you for this great opportunity to present the work that we've been doing at Upstate Cerebral Palsy about building this happy, relaxed, and engaged environment for the students and adults that are in our programs, as well as for the staff and what they experience. What was amazing is to listen to Dr. Steinberg and Dr. Guercio talk about aspects of what goes on in this field, not only for individuals with severe autism, but also what we experience for staff that are in our program as well. And I think it fits in very nicely, certainly, to our work that we're doing around happy, relaxed, engaged. So, I'm going to talk about what we've been doing, particularly over the past year, where we've been moving into this happy, relaxed, engaged model of care, and talk about some outcomes that we're looking to get to as a result of this treatment model. I've packed a lot of info. I know we're trying to hit 3 o'clock as our end time, and I promise that I will get us there. But I'm going to speak quickly. So if you need to, you'll have to go back to the recording and slow down and get all the nuggets that will be in this presentation. All right. Before we begin, I wanted to give you a brief overview of who we are. We are Upstate Cerebral Palsy. What's confusing for most people is that we have cerebral palsy in our name, and that we actually have very few individuals, percentage that we treat with cerebral palsy. The majority of individuals that are in our adult and school age program, as well as our preschool, are coming to us with a intellectual disability with and without autism. Most of this work that I'll talk about today started in our school age program, also called our Trade Winds program. And that work was particularly done with one of our consultants, Dr. Greg Hanley. So I'll be bringing up his name a lot. And I know a lot of people on the in the presentation today on the webinar are big fans of following his work, particularly around the PFA and SBT, practical functional assessment and skills-based treatment model for addressing challenging behavior. This work that we're doing is really to change the culture of our program and how we work with individuals that are our adults and our school age students that are in our program. But we're a pretty large agency. We have approximately 310 individuals that live with us residentially. 72 of those are students in our school age program, and the rest are all adults. Where even though that red spot county is Oneida County in New York, we actually cover quite a broad area in other counties as well to provide those treatment. It's been part of the challenge this past year, certainly as essential workers, to be able to keep everyone safe, try to keep stress level down. And that was what was the neat part around this HRE initiative that we've been going through, Happy, Relaxed, Engaged, is trying to make this COVID period, this pandemic, as stress-free as possible, knowing that there were many challenges that, John already mentioned around staffing turnover, dealing with health and safety related issues, dealing with a lot of changes that we had to respond to as far as personal protective equipment. So it's been a challenging year, and this Happy, Relaxed, Engaged plan fit in nicely to try to keep the stress level low during that time. All right. So one of the things that we're going to talk about this journey that we've been going through, and I always call it a journey, not a destination. So when I talk about Happy, Relaxed, Engaged, we have some programs that are absolutely killing it when it comes to Happy, Relaxed, and Engaged, and they're creating that environment. Other programs that we're trying to lift, and as I mentioned before, we're spread out pretty far geographically. So we're clicking away on this initiative throughout our agency, but it's the goal of ours is to create this environment. And I'm going to talk about that HRE environment coming up in the next couple slides. But here were some of the assumptions that we've been tackling as we have gone through this journey. For me, I've been in the field for over 20 years. And certainly the last couple of years with working with Dr. Hanley and his group from FDF Behavioral Consultants have really been the most rewarding of my career, because I finally feel like we're on the right path to doing the work we're doing. So let me say some of the things that where I said are assumptions that we had in the agency, and I would say for myself personally or professionally, is that we were struggling around does severe autism, does it always have to equate with severe challenging behavior? Can someone with severe autism not have severe challenging behavior? Can you teach skills and decrease problem behavior while creating a joyful and relaxing environment? Individuals with autism, can they experience joy and relaxation while they're working on skills that are going to have a meaningful impact in their lives? And that was a big thing for us, is that, John mentioned before, some of the turnover, some of the outcomes that residential programs show for individuals with autism and other developmental disabilities, such as intellectual disabilities, that many programs aren't getting to those essential outcomes that they want to get to. And I think we fit into that boat. We were keeping people safe, but we weren't getting to the skills that were going to make a meaningful impact in their lives. And I'll talk about how we've been trying to go down and get to those skills through this new treatment model that we're providing. Another thing that was mentioned previously as well, I think Kelly talked about this, is does reducing problem behavior, challenging behavior, does it need to be a painful process for all, not only individuals that are experiencing severe problem behavior, but also the staff that are there working with those individuals? Do we need to eliminate problem behavior before you can work on skills? That was something that we always thought was you need to get them into a position where they're not exhibiting those challenging behaviors before you can work on some things that would have a meaningful impact on them. Is medication the primary solution to dealing with problem behavior? That often happened for us in our residential programs, where we would hit the end of our rope, and the end was medication. This is the only thing that can assist us in addressing severe problem behavior. And so we were really looking at that through this model. And then lastly, severe challenging behavior always have to be managed and not treated. And I think that was our approach around it. A lot of times was, can we keep our head above water, but not necessarily get out of the water? And that's where we wanted to go, is can we provide a treatment model that actually improves quality of life, that you're not dealing with that challenging behavior? Our model in the past for dealing with severe challenging behavior was around behavior plans. That's the way the regulations push you into the behavior plans. And for us, that was behavior plans were provided and implemented by our direct care staff. Those were staff that were coming to our agency with high school degrees, minimal experience in the field, and it really put them into a challenging position to be able to implement these somewhat complex behavior plans. What we found out along the way through this journey is that we did not have the right staffing model in order to provide the treatment that was necessary for individuals with severe autism and severe challenging behavior. And so over the course of the last couple of years, we've been moving into a more analytic model with BCBAs, We're in central New York. There wasn't a lot of BCBAs in our area. And within the next 3 to 5 years, we'll be one of the largest employers of BCBAs in the upstate region, which is pretty exciting for us. And for me, it was the key ingredient to really move our treatment model forward, particularly around skill acquisition. So this is what, when we first started working with Dr. Hanley around a broader model, we had already been working with him around treatment for severe challenging behavior, but we wanted to talk about how can we generally work with the individuals in our program? And both Dr. Steinberg as well as Dr. Guercio already spoke to this issue of how do you create an environment that's safe and that's dignified, and you build strong relationships. Dr. Guercio talked about that. When you build strong relationships, you already decrease problem behavior. And that was a goal for us, is to have more of a shared experience with the individuals that were in our program, that they are excited to see the staff that are working with them, and that they're able to work on some of the skills that we want to get to. And it's not so much of a tug of war with working with the individuals that are in our program. All right, so then we were like, so we knew the general priorities that we wanted. We wanted that safety. We wanted to be a dignified or televisable environment. Someone mentioned earlier on the chat around having cameras in your program. For us, we would want, if cameras were in our program, they were capturing everything that we would want to see happen that was dignified, and that really is this kind of HRE environment. Sometimes that would be a little bit more exciting when you're having a party, and other times it would just be life. But it would be an experience that at any point you would feel comfortable showing it on the evening news, showing it to your family members of, this is the work that I do here at Upstate Cerebral Palsy, or this is the work that if you're talking to a family, this is what we're doing today. That's the kind of experience that we want to create for our staff. That idea of making it televisable really starts to paint an image of a program that we're looking to provide for the individuals that we serve. So happy, relaxed, and engaged. For me, really, you're looking at what does happy mean for individuals with severe forms of autism? That certainly can be challenging with their communication deficits and or some of the challenging behavior that they exhibit. But for us, it's really being able to have a setting that people are excited to interact with one another. They're seeking out staff. They're able to engage in activities that they enjoy, and also that they're not trying to escape that environment, that they're excited to be, whether it's in a classroom, whether it's in a residence or a day hab, they enjoy being in that environment and interacting with others. All right, relaxation. So you want to make sure that when we're having a relaxed environment, that the individuals that are in our care trust that their voice can be heard. I think that's one of the things that we've learned from this process, is that severe challenging behavior is communication. It is telling you that that individual is struggling in one way or another. The function of it, the reason of it for that can vary, but it is telling you that they're having difficulty. But somebody else mentioned in the chat that someone exhibits severe challenging behavior when they're really excited. And so that still is telling you that they're excited about whatever's going on in their life. So it doesn't always necessarily need to be something negative, but many times, and the majority of time for us, it is usually indicative of more of a problem that they're experiencing. Dr. Steinberg talked about anxiety, right? And that's something that certainly a lot of individuals with severe autism experience, individuals with other developmental disabilities experience as well. And that our goal is to try to keep that low so that they're not experiencing that. Dr. Guercio talked about the ACEs, and you could look at, for individuals with severe autism or other intellectual and developmental disabilities, that those ACEs score would also be very high. They've also experienced a lot of difficult, adverse situations. And we want to make this experience at Upstate Cerebral Palsy a very caring, loving experience that they're going to feel comfortable being in our programs, whether it's in the residence or in our school or day programs. And the last one is engaged. Looking at ways that they're engaging with others within that social environment. You know, for me, oftentimes with individuals with severe autism, particularly when I was new to the field, is that I struggled with how are we going to kind of get into their world, and that oftentimes staff were pushing them into our world. And I think that's one of the things that we look at is what are the ways that we can better understand what makes them tick, what makes them enjoy life, and how can we experience that with them through that rapport building, through that time sharing activities or environments that they enjoy. We're able to build very engaging relationships with strong elements of rapport. All right, I'm going to breeze through this part. Big thing is, you know, when you look at big picture around severe challenging behavior, at least for us in the past, was like, we just want to decrease it, right? We want to make it a safe environment, but not really thinking at broader outcomes that you want to get to. As part of our HRE strategic plan, we really looked big and we were aiming high around how can we get to exceptional outcomes that address a lot of issues related to severe challenging behavior, but also address issues related to individuals with intellectual and developmental disabilities. These are our areas that we cover. I'm not going to go into too much detail, as I mentioned before, but they're things for us to think about in the field is how do we measure outcomes that are important and meaningful? And at times, just because you're decreasing challenging behavior doesn't mean you're not increasing other areas of concerns. So we can, you know, certainly looking at polypharmacy is a big area of concern within the field of developmental disabilities, and that you can reduce challenging behaviors through polypharmacy or through psychotropic medication, but that's not the goal, is to do that. You want the right medication balance that they can still have a quality of life and develop skills. And that's all on there. All right. So this is some of the primary work we did around with Greg and Dr. Hanley is around our universal protocols, is to make that kind of experience. This fits in very well with what John mentioned previously around his approach that he uses. But some of the big things to mention, and these were things that we would often talk to parents that were at home with their son or daughter during the pandemic, and they were struggling around problem behavior. And the first thing is we were looking at how can we take some of the heat out of the kitchen. And these were the things that we find to be most helpful around that. Looking at ways that you're continuing to build that positive relationship. So you'll see a number of things in there as well, allowing that person to make choices, to follow their lead. The biggest thing that we were looking at, though, is how can we decrease non-essential demands or denials, particularly when they're already showing precursor behaviors or warning signs to challenging behaviors. How do we keep that low, those demands and denials, to not increase the likelihood of more severe problem behavior? Part of that is the field is looking at is moving away from escape extinction approaches, particularly around severe challenging behaviors, as a way to address those challenging behaviors. We do address challenging behaviors, and I'll talk about that in a minute, but it's more of an expert-driven approach. The other things that are on there as well is, you know, we want to look at reinforcing early warning signs. So when you start to see those challenging behaviors start to spike, you're going to look at ways that you can decrease that by reinforcing those early warning signs. We do want to get to toleration. We do want to get to essential skills, but we don't want to increase challenging behavior along the way. We do not see challenging behavior as part of the process in order to get to those skills. And I'm going to show a quick video here around what this HRE environment is like for our staff.
We've always been an organization that embraces self-reflection and strives to improve the quality of services and supports we provide. We were not seeing the positive outcomes that we desired, and we realized we needed to work differently. It wasn't until 2017 when we developed a collaborative relationship with Dr. Greg Hanley.
Sorry about that. Oh.
We've always been an organization that embraces self-reflection and strives to improve the quality of services and supports we provide. We were not seeing the positive outcomes that we desired, and we realized we needed to work differently. It wasn't until 2017 when we developed a collaborative relationship with Dr. Greg Hanlon and his team. We were missing critical elements of skill building. Through our work with Dr. Hanlon, we realized that the cultural change that we were creating was for everyone.
What we've done in the past is taken really good care of people, but what we found was that we weren't enriching their quality of life. We weren't helping people become any more independent by what we were doing. We decided as an agency that we really need to leave people with a better quality of life, more independence, and we need to teach them skills. And so Universal Protocols and HRE gives us the foundation to do that. So a lot of what we were doing falls right in line with Universal Protocols, but now the ultimate goal is to teach skills.
I think the switch has occurred because of a general development in the field as a whole. I think we've come to a place where we've realized that there's a balance between what we're going after. We want to build skills, but we want to do it through a happy, relaxed, and engaged life.
Let's just make kids happy, relaxed, and engaged. Not everything is a battle. We're going to invite kids to participate in things. We're going to limit our demands to only essential demands. We're going to follow their lead. We're going to provide positive regard and empathy, and we're not going to be overly directive. And then once we have those nice relationships, then we can start to teach skills. But when you teach skills from this directive relationship, it doesn't really work. We do stuff with kids and with adults. We don't just stand there and direct them we're going to create a shared experience. You're going to roll some, I'm going to roll some. That's how work works.
We have our classic sort of parenting way of doing things where it can be directive and we can have high expectations. And so sometimes parents are a little worried that by providing this happy, relaxed, engaged context that we're not also upholding some of those high expectations. And so we reassure them that this is actually the pathway to those high expectations.
I think staff have really worked hard to embrace it. It is a shift in how we used to do things in terms of being overly scheduled and overly routine and overly demanding. And I think it's empowered staff to be able to think critically, think in the moment, think ahead, which is an exciting place to work when you're able to use, your own judgment and not just be so tied to, did we do this check? Did we do this check? And kind of having to endure some problem behavior because of these check boxes.
We're going to train, we're going to monitor programs to make sure that they get it, that these are the behaviors that we want to see from you in these types of situations. You see warning signs, back off. Think about that as the person's voice and that something's not right, and you can back off in that and it's okay. But our long-term goal is also to bring in the Essential for Living curriculum so that we can identify key skills that are the most functional skills that are going to most improve their quality of life. And so it's going to be the combination of those two things, finding HRE and moving into skill building.
We've seen happier individuals that we support and teach and happier staff, right? Because the staff are not dealing with much severe problem behavior anymore, and the people that we support and teach are trusting us more. They're saying, oh, I don't have to, have the severe problem behavior to be heard. Because behavior is communication.
So our journey continues.
Happy, relaxed, and engaged means to you, Tyler. Play on my phone. Have fun with that. And a nice house.
Happy when it gets engaged, everyone's happy.
All right, so I love that statement at the end Alex make is that happy, relaxed, engaged means everyone is happy. And that's really what we're shooting for, is to create an environment where people want to live and to go to school and people want to work. And that's something that everyone can benefit from. So here's our model, broad model here, Universal Protocols up top that we just talked about. That's our broad way that we're going to work from the previous slide that I just showed before the video. But then what happens when you still have severe problem behavior? And that really gets into more of our expert-driven approach. So we have more of an expert-driven approach that we're going to use with our BCBAs that are going to be implemented around Dr. Greg Hanley's PFA SBT model. We have an expedited, more consulting approach around severe challenging behavior that's less frequent, and that we're going to be doing that in the residence, in the school, and in the day programs. That's something that we've been rolling out during the past year. And so that would be led by the individuals in those environments. And then finally, if you're in the green, which that's what we're shooting for, is like no problem, no severe problem behavior, then we're really working around our essentials for living assessment and curriculum. And this gets at some of those essential skills that are going to be so important to improve the quality of life. So let me talk a little bit about our expert-driven approach. It's the practical functional assessment, skills-based treatment. Can't say enough good things about this model and what it does for our BCBAs to be able to provide treatment in our program. This one was the game changer for me in my career. Finally felt like we had our clinicians in the best position to impact problem behavior. I will mention before I start the video is that there is an instance of aggression that's in the video. This was done, video was taped by permission by his mother, who was a great advocate for us in the work that we're doing. But also, as mentioned previously, is that some of this stuff needs to be shown, and that we are able to get to outcomes. We're able to work through it. So you'll see, hear a little bit more about Joey.
Joey was diagnosed pretty early, pretty young, and from early on, we knew that he probably would be on the more severe end of the spectrum. It was clear that he was profoundly affected in every way from his disabilities. Prior to his coming to Tradewinds, Joey had a lot of aggression and self-injurious behavior. And I know, those are words we use a lot. I think I hear them all the time. And I feel like sometimes people don't really know, what does that look like? Or, to what degree does this child display aggression and self-injury? And in our case, Joey was in and out of hospital placement. Any given time I could call the hospital and they considered him acute crisis based on the behavior that he displayed on a daily basis. We had actually leased an apartment to separate our children because we could not have all three of them in the same house due to the level of aggression and the danger that it posed for them. So we were separated as a family prior to his going residential. We still saw a lot of the aggression, still really had trouble with that. I felt like, we were being careful about the demands we were placing on him, which made me nervous as his mom. There's only so much time I felt like we had left in school to have teams of people help him. And I also felt like he's only getting bigger. So these things have to get worked out. So, I think it was in the past couple of years, particularly this past year when he joined this program, that we really saw gains. And my favorite thing that has happened in the past year since he started your program, my phone rang and I picked up my phone and it said FaceTime, and usually his staff would help him FaceTime. So I thought, oh, okay, must be. And I answered and it was in the room. And the lights were off and he was sitting in his beanbag chair and he was upset. I could see that he had a rough day. And he had called me because he was upset. And the thing about that is, one of the hardest parts about having put him in a residential facility is that I know without his words when he has to be there for him home. But other people aren't going to necessarily know that it's a bad day and he really needs to call. So when I was asked, the answer was, how charge his iPad and FaceTime me, because that felt like the biggest hurdle in his ability to independently FaceTime. Sometimes he would get the FaceTime part right, but he never got it right if his iPad wasn't charged. So for me to find out in the way that was the actual reason and motivation for me asking to work on that was huge. And it was probably one of my favorite moments in the last couple of years of Joey. I really, since he was 13, have had a hard time with, and knowing that on those tough days, would I be able to be there for him like I want. really say other things like, you know, knowing that people take seriously when I ask to think about meaningful employment. There's a lot of people that would just sort of kind of pat me on my head and be like, oh, I've met you. But people really believe that Joey can in fact do this, and they see that potential, even though he's a kid that needs a lot of help. Quickly, and maybe but there's some things that isn't, you know, the quickest that he picks up stuff. So for me to be able to have people who are approachable and hear what my real true wishes for him are, not just what I think people want to work on or want me to say, but if I want to say to them, help him plug in his iPad and help him learn to be a busboy, that is so well received. All about opportunities. At the same time that you're talking about opportunities, you're talking about working on the things that may prohibit those opportunities. And so it's those two approaches in conjunction that's really, I think, the magic of this program. For us, most definitely, I feel like there was a lot of people that probably gave up on him a little bit, which is why I spoke to earlier, being so grateful that this is a team of people who, it doesn't matter what I say. If I say I want him to work in our restaurant, no one says this is why that's probably not realistic. We work on it and we assume that that's possible. I think that's the difference. It's all about assuming possibility with kids, even kids who had dramatic aggression like my son. I think there's a lot of families that may say, that's great for this person's kid, but I don't think my kid can do that. And I feel like Joey really has a lot of impediments to his ability to just be comfortable in his own space and to be able to learn among everything else that was going on in his life, in his world, in his head, or whatever else we don't know. And I truly believe that all of our kids, no matter where they are, no matter where their aggression is or self-injury is, that we can create meaningful progress for him. And we did, you know, for Joey. So I truly believe that.
I always love that video. Bobby does such a nice job of communicating out the importance of the work that we're doing and how we can impact lives. So she mentioned, you know, about these skills that he's working on. Certainly, you know, for us, the practical functional assessment and skills-based treatment, you're going to be working on skills related to communication, functional communication, particularly related to the challenging behavior. You're going to look at toleration skills, and then you're going to work on contextually appropriate behaviors or skills that you want to increase. What we found through the process of working with Greg is that we often didn't know what we should be working on. You know, in our school, we were having a lot of worksheets that really didn't make sense for individuals with intellectual and developmental disabilities. And so over the past year, we've transitioned into our Essential for Living assessment and curriculum model for identifying goals to work on outside of any work that we're doing around skills-based treatment model. So this is something that's so important to think about for individuals with severe forms of autism and other disabilities, are what are the key things that staff should be working on, particularly early in life as much as possible, so that we can have those children being able to communicate, to tolerate, to engage in skills that they need before they become bigger, and that becomes more complex to manage and to treat. So these are what we've been working on. We've also been working with Dr. Hanley on his preschool life skills that we're using in our preschool program, and that is pairs very nicely with the Essentials for Living curriculum. All right, we're done. So last thing I want to mention, that YouTube that you just saw, or the video that you just saw, you can find it on our YouTube channel. I know that somebody texted me that the sound was a bit choppy. It won't be choppy if you go through that route. We got some other videos that are up there as well. We're on all the other social media pages if you want to hear more about our journey or more about the organization. I also can't say enough about our consultants that have helped us really start to transform our program and the work that we're doing. Dr. Hanley, Dr. Camilleri at FDF Behavioral Consultants, in addition to Shannon Ward, Kelsey Rubel. Those are been an amazing group to work with and really transform the work that we do. Dr. Pat McGreevy, Troy Fry at Essential for Living, our pyramid consultant, Joanne Mateo, and the work that we've done with PECS, as well as Megan Miller from the Do Better, who's been helping us work around some of our more complex learners that we're really trying to understand their HRE context better and to help us get into their world better so that we can build those relationships. Megan's been working with us around some of our more difficult cases. And that is all I have, Kelly.
Thank you. That was awesome. John, if you're on, Eric, if you can stop sharing your screen and John pop on. And Robin, if you're here, I think you might have jumped off, but I just wanted to say, yes, you're here. So they say to surround yourself with greatness. And so I personally, when I was asked to host this, I wanted to tell this story. And so I found the people that to me were right exactly where we need to be in this industry. As someone who's been doing this for 27 years now. So I hope you liked our story. Where we started with the medical information, talked about that to the appropriate assessment and care and consideration, all the way to the treatment. And there are some takeaways from that. In my opinion, we can do this another time and go even deeper. We probably have a lot more work to do. But what's going to happen is so many people are going to say, how do I get this kind of information and training to my ABA providers, right? And so I know that the three of us were actually, or maybe the four of us were talking about maybe doing a panel at some conferences together. Frankly, Dr. Jacobson and Dr. Guercio, you don't need me on your panel, but I do like to get this message out when we are promoting our approach and our therapeutic work that we do, that these key core components are part of the decision model making. And so we're going to end. I'm so sorry. We tried to address most Q&As in the and in the chat. I'm putting my email in here too, if people want to reach out.
Kelly?
Yep.
It's Jill. I'm just butting in for a second to say that in your discretion, if you want to go on for a little while longer to have a discussant and take another question or two, please feel free. I know we're over time, but it's such an important topic. If you want to, it's up to you.
Sure. Steve, if you could hop on, thank you. Steve Perez, he's my colleague at People's Care, Behavioral Health and People's Care. He's our discussant for today.
Hi, everybody. My name's Steve Perez. I'm a BCBA. This was a great mix of expertise and information, and I'm just amazed to have all this great information presented in a short period of time. As Kelly said, it's understand the body, understand yourself, and understand those who you're working with, all kind of rolled into one presentation. This is great, and it's great to be here.
Go ahead. Do you have a summary?
A summary of the presentation?
Yeah.
Oh, I don't think there's anything that I could say that would add to all the content that we have. I think it's best to just leave the content as it was presented. I don't want to, I'm not going to place my, I can't do any better work is what I'm going to say. And I think it was just amazing. And I'm still in awe.
Thanks. Any of our panelists want to comment or make any last comments?
After listening to the other two presenters who I thought were great and I learned so much from them, the thing that stands out to me is as a physician who works with these families, a lot of my patients are in the transition age group, and they are working on independent living skills and finding a place in the world. And the one thing that I think we really need to put pressure on our different communities is to have more options for people on the spectrum, because it's either they have a day program or they have very limited supported employment opportunities, or they're left on their own to try and fend at a higher level. And at 18 or 22, depending upon the person, that, as someone mentioned in the chat, you have the services cliff, which is real. and trying to figure out how to support those families as they as the kids turn into adults and into adulthood, because we really don't have a lot of services or a lot of different programs or options. And I think that's really frustrating.
And I'd like to make a comment as well. You know, I think that one of the things that, you know, I've heard from all the panelists, which I think is the direction that this field is going, that is totally against the anti-ABA movement that has been out there. And I think Dr. Epstein referred to this and talked to it a little bit, but I think in watching Dr. Jacobson talk and seeing that we're now focusing on choice, we're now looking at being invested. And I think Erik at one point mentioned, you know, entering into their world. And I think these are the things that a lot of the arguments are posed that our field is not doing. And I think that's what we need to do more of. We need to get more of the personability out there of this and how this is framed with the individual, and the treatments are actually targeted towards them. But I think also looking at the manner in which a lot of these requests are made. I think anybody that, you know, is in that spot where they are relaxed and then they're engaged, I mean, those types of things have to happen first. Whereas I think many times we focus too much on, well, let's get the task done, then we have the reinforcer afterwards. Well, life's about reinforcement. So I think that if the way that we maximize that, I think the better that we're going to be. And the more that we maximize that, I think the better outcomes that we're going to see for everybody involved. So I appreciate being a part of this. It's been a fantastic learning experience for me.
Thank you. I think that, you know, the field of ABA has been on a journey and has a story just like that we're describing, you know, from the 80s, Lova's, well, long before all that. But I do think, you know, the movement towards happy, relaxed, engaged, the movement towards what are the essential skills that we need to be focusing on, rather than the sort of escape, extinction, compliance-based approach ABA has historically had, is a really important takeaway. Along with, there was some conversation in the chat about, you know, traditional FBAs, and as ABA practitioners, insurance companies guide us on what assessment tools. They tell us what we need to do, but we don't have to do just those tools, right? And a lot of ABA companies are struggling because they're trying to do the tools that the insurance providers are telling us to use, but it's not getting at what we really need, which you all just described. And so as practitioners, we have to work harder to get that information, but it does mean we can do additional assessment tools. We can use, you know, the tool, your book, John, we can use, you know, the essential living skills. We can use all of that and add it. And I think that as practitioners, if we know what if we're looking at skill acquisition as the goal versus focused on the decreasing problem behavior, which is the insurance-driven approach, but instead the strength approach and skill acquisition that are important for that adult or child in that family in that moment, like your video, that's the way our field needs to go. And you guys are living proof that you're going in that direction. And I know, Steve, I happened to tour one of our day programs in Temecula yesterday, and that's exactly what was happening at that one. It was happy, relaxed, engaged in that approach. And so I saw also on the chat, someone say it's not rocket science, and that's true. It's not actually rocket science. So go ahead, John, if you're going to say something.
No, I think we make it rocket science, and it's not.
Yeah,
and I think that's the thing. We look at it, it's all these complex issues, and I think that if you just look at the basic human dignity and interactions that you would want yourself, then you've got it. So exactly. I think that's right on.
One of the neat things that's happened during the course of the past year, once we started moving our EFL as the main assessment tool for our IEPs in our school, is the collaboration across disciplines, from clinicians to teachers to SLPs, OTs, PTs, is everyone was coming together to say, what's the main thing that we should be focused on during the day? And that really was, you know, those essential 8: for us from that EFL was really like, how do we do this across disciplines so that this child, when they leave and they hit that cliff, is they're most prepared to enter into a different world where services aren't there. And we always talk about that with our leadership group, is that when students hit our program, in our Trademan's program, we're on the clock. And that these students, these parents are counting on us that when they're an adult and they're 21, that they're going to be the most prepared as possible. You know, we do need to address the issue of the shortages related to adult services, because I think you move into that management model. What's been neat is Upstate Cerebral Palsy has moved into, or has collaborated with school age program and into our adult program, and that we're hiring BCBAs into our adult program, which isn't something that's regulatory driven. They want to push FBAs, they want to push BIPs, but the regulatories allow it. Nice thing with us is we don't have any billing or anything else kind of predicting how we do our work, but we do need to meet the regulations. So just some neat stuff that's going on that it's just kind of emerging, and as we're moving down this field.
Great. Thanks everyone so much for your time, for staying on. As we mentioned, it is being recorded. Jill will have it out to anyone who registered, and it will also be on the social media. Thanks.
Excellent.
Great.
Thanks, you guys. That was awesome.
Thanks, everyone.
Thanks for everyone.
Thanks for sharing our story.
Thanks to everybody who attended.
Bye.
Bye.